Good morning. Camera.
Good morning. This is Steve Stites, Chief Medical Officer for the University of Kansas Health System. I'm here in the Dolph Simon studio with my colleagues and friends. We're broadcasting live. On my right is Dr. Dana Hawkinson. He's got a few aliases now: Hawkeye, Doc Hawk, Goofy. And on my left is David Wild. David Wild. God, I knew I was going to do that. Keith Sale.
I can be both.
Don't even
really,
look alike.
Yeah,
okay, we're off to a great start. Keith Sale, who is also a good friend and colleague. Keith is a Vice President of Ambulatory Services here at our health system. And Keith has done a great job. He's also a very prominent ENT physician, and we are delighted to have him joining our program this morning. So good morning out there to our audience. Dr. Hawkinson, how are things going?
Hi. I think they're pretty good. I think that all of our sheltering in place and social distancing, physical distancing that we've been doing for the past 4, 5, 6 weeks has been paying off. We may be at a new steady state or normal as far as the hospital goes with hospitalized patients and critically ill patients. We're sitting about 26 patients, and 11 of those are in the ICU. So everything that we have been doing has hopefully stemmed the tide of these critical illness and need for our ICU rooms and our ventilators. And we also have been conserving our PPE, our personal protective equipment as well, so that's a good thing.
It is. It feels like this is our new normal until there's therapy for COVID. I just want to say, early in the show we said BKC, right? Be Kansas City, because we knew we could do that, and we've done it, right? We've done it. We really have. We have flattened that curve, and we've been at the same level for a couple of 2 to 3 weeks now, and I think it goes up and down a little bit depending on where the most recent outbreak is. If I know that if there's a nursing home that has a lot of patients or some other place where there's congregate living, then what happens is you have that steady stream from there, and then you have some folks coming from the community. But this is kind of our new normal for now, and as part of that new normal, we've had to adapt how we do things, and one of the most important adaptations, Keith Sale, is telemedicine. Talk to us about where we are and that. Kind of give us a little bit of an overview.
Yeah, so about 5 weeks ago, we had to really kind of pump the brakes as we reduced our patient visit numbers to try and maintain patient safety and staff safety. As a result of that, we dropped to about 35% of our normal visits. In doing so, we had a lot of patients who still needed some type of health care, and so we had to try and fill that gap. And so telehealth was a great tool to do that. We were able to, over the last 5 weeks, really ramp up that service, and now we're back to about 75% of our volumes in total when you mix our in-person and our telehealth visits. It's been a tremendous process to go from roughly 500 telehealth visits a year to now over 25,000 in the last 5 weeks or so.
Yeah, it is remarkable, I think, and how well that transition has gone. I think we're going to kind of talk about telehealth this morning. We're going to talk a little bit about what the future holds, obviously answer your questions. Just to plug and a heads up about tomorrow, there is a David Wild, and David was going to join the program. He's our Vice President of Business Intelligence here. He does a lot of work with modeling. He works very closely with the university, and together we've worked pretty closely with different organs of state government and local government to think, what's it going to look like around modeling, and what do we expect to happen as we begin to open up society again and people return to a little bit more of a quasi-normal life. With him will be Dr. Terry Sue, who is our VP of Physician Affairs and who is also the Medical Physician Director of our cancer program. And I think it'll be great to have those two folks together. They'll be talking a lot about testing, and they're going to be talking about how we handle surgeries and how do cancer patients handle surgeries, as well as this concept of how are we going to model looking at there. So David, did I go again? Do you know you?
Yeah, I can get David.
Maybe you should. Although you don't look a thing alike. So Keith, as you look at the future, what do you think this mix is going to be like? Are we ready to say it's time to stop telemedicine? Let's just go back to bringing everybody into clinic, or how is that going to happen?
But I really hope that telehealth is here to stay. I think we have spent a lot of time and effort to get this platform up and running. I think it is a tremendous service that prior to COVID was limited by restrictions and by variable coverage, I think now all of those restrictions and coverage limitations have been removed, and we can now provide this new amazing service to really anyone, anywhere. And it's fabulous. Our patients are universally loving it. Our physicians love it, and it's a great way to keep our people safe. I think long term, as we look at the COVID pandemic and our recovery from it, there is still a place to have physical distancing, to have ways to reduce transmission of this virus until we have a way to have immunity from it. And so I think as a result of that, our clinics are going to continue to be a blend of telehealth and in-person visits. And I think we have to figure out the optimal balance for that. But over time, I think it's going to be a great way to reach as many patients as possible in places that we've really struggled to get patients to come in from in the past.
So, it feels like, and I've done a number of telemedicine visits now, and I'm actually doing an in-person visit today, and then next week I've got a bunch of telemedicine visits. So I think it's interesting to do it. What I think for a lot of folks, even without COVID, it's pretty darn convenient. And the other shocker is I'm on time. I don't know what makes the difference because I'm usually not.
Yeah.
But I'm on time. I'm even early. The nurse who I work with keeps saying, okay, I know you're going to be shocked, but Dr. Stites is actually early. Are you ready for us to go? So that doesn't usually happen. But what do you think? Because I think even without the coronavirus, there's an advantage to us to be able to offer telemedicine to a lot of patients, especially, as you mentioned, people in areas that don't have specialty care.
Yeah, I think, again, this is a great opportunity that we really should be trying to take advantage of. We've had a national physician shortage, and that we've known about for a long time, and we have a backlog of patients who need specialty care across the city, across the country, for that matter. And so this is a tremendous way for us to reach some of those patients that we've otherwise had trouble getting to. And it's a way for them to connect fairly easily and conveniently from their own homes to either our physician offices or even our physician offices in their own homes. And so is a way to maintain that physical and social distancing. This is not only a great tool for that, but it also allows us to do that and provide care to patients that maybe in the past we couldn't reach because this tool wasn't available to us.
Yeah, it's remarkable. So let's turn to team media out here and also our listening audience and see what questions folks have. Have we answered all the questions that are fit to ask? Okay, well, I'm going to ask a question. Does anybody else have a question though before I jump in?
Hey, Dr. Stites, I had a question. It's not about telehealth, but somebody had asked a question yesterday about how they've seen a lot of healthcare workers posting about self-isolating at home in the basement or in another bedroom to protect themselves from their families. And is it necessary? And do you have any recommendations? This person happens to be married to a paramedic.
Okay, Dr. Hawkinson.
Yeah, that's a good question. We certainly have seen a lot of media reports or social media reports about this, about healthcare workers doing that. It's really, I don't understand if it's the healthcare workers trying to protect their families or if the healthcare workers want to protect themselves from their families, depending on, who people are interacting with. We shouldn't really be interacting with other households because that's when you can really get the infection, or if you're out shopping and things of that nature, get it, bring it home. So it's really hard to say. I think this boils down to individual decision and how careful are you. It's hard though. It's hard if you have to either shelter away in a treehouse. I think I saw a story about that on CNN, or down in the basement or in a garage apartment or something of that nature. It's hard to do that, and how long is that sustainable? Because especially as we seem to open up soon, this infection will probably be with us for some time. And even if you see the reports about as we move into the next few weeks into the summer, what they're predicting to do. So that's really hard, and I don't know how sustainable that is. That certainly just goes down to individual preference and if you can do that. Mostly, you want to keep yourself safe, you want to keep your family safe. So other than that, I think there's not much more than individual preference and safety.
Yeah, that would be my answer as well. I think some people feel like they're in an especially exposed environment. And so there are some folks who come in, they have shoes that they only wear here, they change into scrubs when they get here, they put on their shoes they only wear here, and then they go do about their work, and then at the end of the day, they change out of their scrubs and put back on their clothes, go home, shower, and then maybe go in the family. People are doing a lot of things in order to try and keep other folks in their household safe. I think one thing that really may affect that is who else is in your household, right? So if there's other people who may have chronic illness or who are older and you're trying to protect them, you'll do everything you can. Part of it is we just don't know enough about coronavirus. Part of it is, we know a lot about coronavirus, about this particular SARS-CoV-2. And part of it may be that I think people, out of an abundance of caution, are trying to keep them safe. And I think that the lesson that we have to learn from that is that when fear exists, you try to do the best you can to protect the people you love. And what I want to emphasize, one of the most important points that we want folks to hear is that even when government starts saying it's okay to go back and do whatever it may be, you still have to have a very healthy respect for SARS-CoV-2. SARS-CoV-2 is not gone away. We have, and we've had, as I said as you said a few minutes ago, we have around 25 patients that are in the hospital, and about 10 or 12 are in the ICU and are on ventilators, and that's kind of been where we've been since after about 10 days of sheltering in place. When we actually saw it, we saw ourselves peak, and then we saw the sheltering in place take effect. We've kind of been at this baseline level. And I think what the lesson for us is that with all these great measures in place, there's still some social contact, there has to be. And what happens is there's still some spread of the virus, especially in like nursing homes and places where there's a congregant living situation. That produces X number of cases, and we're just going to have X number of cases until we've gone through all congregant living facilities, or until we have a vaccine, or there will be some patients who just keep coming into the hospital because there's some community transmission. As we open up society, there is a risk, in fact, a great likelihood, that the number of patients we have in our hospital with COVID-19 will go up, and we'll have another new baseline until we see another. And that's what we're going to live with. It is here in the community. So just because we open up doesn't mean that COVID-19 is any less of a risk. Because once you start going back out and you start going into bars and restaurants and churches and schools and places like that, you'll see a rise in cases. As the cases rise, then we'll just have to adjust and do it. But the best thing you can do is what we keep saying. If you're going to go out in public, you have to, you guys, I bet everybody here can probably say what I'm going to say right now. You got to socially distance. You got to wear a mask. You got to wash your hands. You got to not touch your face. You got to cough into your elbow.
And to your point, Dr. Seitz, in a bigger picture about our health system here, healthcare workers, especially here, we don't have a need for beds. We don't have a need for ventilators. We don't have a need for PPE. We have all of that stuff right now. We didn't see a large surge yet. So we also have our training. So here, in the hospital, in the health system, you are safe if you need to come here for treatment because everybody is doing everything properly to get people who may or may not have COVID to the right area, to keep themselves protected, to keep other patients protected. And I think our employee percent positive rate is the same as a community or even better. And even those patients, those healthcare workers that have been taking care of COVID patients, certainly their percentage of people who are positive for COVID is much lower than in the communities. So we have all those precautions in place too.
Yeah.
Well, Dina, we're doing the same things in the ambulatory, right?
Yep.
So as you think about how you protect your staff and your patients as they come in, we're trying to be as safe as we possibly can for both those groups. One of the things we do is we have our screening stations, right? So as you come in the front doors, we're checking for temperatures. We're also, as we begin to think about reopening, talking about how we can screen patients before they even come to clinic. So how can we identify those patients with COVID or COVID-like symptoms before they come and maybe redirect those folks towards a telehealth visit rather than having them physically come into the clinic. We're doing things like maintaining our no visitor policy, and we certainly have exceptions to those policies, but largely they will stay in place as they have been during the COVID experience. I think adding things like physical distancing is also really important. And so as we open up our ambulatory clinics, a couple things become really important. Number one, we can't continue to see the same volumes of patients and visitors through our organization as we have in the past. We'd see roughly 10,000 plus people come through our organization on a daily basis to our clinics. And so to try and control that flow of people and maintain that physical distancing, we have to reduce those numbers and also spread out the time frame that they're coming in to see us, probably over a longer period of the day. So as opposed to having a 6 or 7 hour day, it may be an 8 or 12 hour day now.
Yeah, I think that is the future, again, until we see effective therapy, until SARS-CoV-2 makes some decision that it wants to go away, which I would applaud, by the way, or until such time as we have immunization. Questions?
I have a question over here that kind of, to paraphrase, plays off what you just said, Dr. Sale. They want to know, how are you going to keep me safe if you're going, if you're seeing 10,000 a day? They didn't know that number, but they're like, telehealth is great, but I need to see my doctor. I'm afraid to come in.
Yeah. Well, first and foremost, that 10,000 number is patients and visitors, and so by reducing the visitor piece, you really cut that number in half. And so you're down to roughly 4,000 patients a day in our normal practice, 4,000 to 4,600 a day at full business capacity. And so I think prior to that, or since that, we want to try and change that and reduce that number of in-person visits to closer to 3,500 as we ramp up. And so that'll be a combined in-person and telehealth number. We want to maintain our telehealth clinics as well, because I think that helps to also contain that volume of patients that are coming through our doors. Lastly, like I mentioned, we want to separate the times between patient arrivals. And so as patients come in and they go through that screening process, they will also then go directly to a room. And so we have a history of queuing patients at our check-in desks, having our waiting rooms filled as patients try and go through the clinic process. But by spreading out those patient visits over the course of the day, not only can we directly bring those patients into their exam room, we can also do their registration and check-in process in that exam room so there's not people waiting in the lobbies as well.
You know, it's interesting. I was trying to think of which patient I'm going to see in person and which not. And there's some I feel like I need to have that in-person visit, and maybe that's just because I've practiced that way for, approximately a very long time. And but the other thing is sometimes I just want to listen to somebody's lungs. So I've been trying on a telemedicine visit to tell people to take a really deep breath and blow out really hard at the microphone. Now, I think what I do is create a lot of aerosolization of secretions. By doing that, I'm not sure how much I really hear, but that is one part sometimes you just want to listen to somebody's lungs. It's interesting, in our population in cystic fibrosis, one of the things we really like to do is measure lung function. Well, we were able to get a grant from the CF Foundation, and then some of our physicians made donations, and we were able to buy a lot of spirometers and send to patients, and they've been checking their lung function for us at home. It's interesting the adaptations you can make when you have to. And I applaud all the patients out there who have learned to Zoom and to do different things, allow these telemedicine visits to really to go and to thrive. And to you and your team, you guys have done a great job of getting us ready to do that. Other questions out there?
Yeah, this is Nate again. What are your thoughts on dental offices opening up on May 4th and seeing patients for non-urgent preventative services? Is it safe?
Yeah, that's a great question. If you look at the list of professions that have the highest exposures, there are a couple, and dentistry is high among those, along with ENT physicians and respiratory therapists. Dana, what do you think? Dennis, is it safe?
Yeah, that's an extremely hard question to answer. We were on the phone call with Wuhan. They had described that they were still going about their daily business, and they really focused on their ENT physicians, their dental hygienists, and their dentist offices as being really areas of super spreading, because before it really broke out, this virus was probably going through that area in this dark, insidious way, and then by the time it hit them, it was all upon them. So certainly I think dental offices are very risky for the healthcare providers, because we still don't know that we know that you can spread the disease even if you're not having symptoms. And they've detected it actually now in people even up to 6 days prior to symptoms. I don't know how infectious you are, but certainly we know 1 to 2 days prior to symptoms, you can be pretty infectious. So that's a very dangerous thing. I think we need to kind of see what the industry, their guidance on that, as well as further public health guidance. We certainly would recommend very good personal protective equipment, masks, face shields, and things of that nature.
Yeah, I think it's still, gosh, I don't know what you'd say to PA patients and what you do around that. And both for the dentist and the dental hygienist, I think it's risky to them. And then I think it's risky to the patient just because you have such close proximity for quite a while. So I think, we'll find, it'll probably have to be something we have to work to find out. I do know that a dental office without PPE is a place I wouldn't go. I think with really strong PPE, then I think if you're feeling well and asymptomatic and don't have a temperature, I think, again, the risk is to the dental team because you're the ones that are going to spread to them as long as they've got on all the really good protective equipment. What comments? Because you're a super spreader. You're an ENT doctor.
I'm a super spreader.
Yeah. That's what
not
he
very
just
nice.
called you.
It's not very nice.
He just said, well, no, I mean,
Yeah.
Okay. Super spreading.
Yeah.
Okay, there you go.
No, I think PPE in the ambulatory environment becomes really important, and I think it continues to be extremely important in those areas where there are potentials for super spreading. And I think our dental clinics and our ENT clinics are some of those areas. And so how we reduce or manage the flow of patients through those areas is really important, because I think we have to reduce the number of rooms potentially even further. We have to spread providers out over multiple rooms. We have to have rooms that can actually lay open for a period of time after we use them for things that may be aerosolizing type procedures. For our dental colleagues, it's an even bigger challenge. Like you said, they're traditionally not in individual exam rooms, they're in individual exam spaces. Now, our dental clinic, I think, is a little bit unique in that we do have specific rooms where I believe we can close the doors, and so we potentially could start to move patients through those spaces as well. Again, trying to leave rooms that have had aerosolizing type procedures closed for a period of time after use. We're still working through the details on that and working with Dana and his team and our infection prevention and control teams to really identify the most ideal way to move patients through those type of environments, but those are the biggest challenges that we have in our health system as well.
Yeah.
Yeah, and we can't underestimate the importance of oral health, dental health. We know it's important, and people have to get to their dental cleanings. They have to get evaluated if they're having problems. I've had patients in the hospital who, more times than not, who just thank me when we can get them some dental health here in the hospital. Absolutely. Because it is difficult to get out. So that can cause a lot of people a lot of problems and pain and poor quality of life. So we definitely know and understand that dental and oral health is extremely important, and we need to get people working again and providing those services. It just has to be in an extremely safe manner.
And I think here's the bottom line is when we reopen society and dental offices open, COVID-19 is going to be with us until there's a vaccine or until there's therapy. That could be 6 to 12 months. I mean, there was a group yesterday out of Oxford, England, reporting that they had early success in a monkey model with a vaccination. They hope they could be ready as early as September, but they're just starting clinical trials in people. So that's the shortest timeline I've seen for a vaccination, and it's kind of it's real early to even be optimistic about that. But let's say it's 12 months or 18 months, which is probably more realistic. Does that mean that nobody can go to a dentist for 12 to 18 months? And the answer to that is, boy, that's really tough. So what you have to do is the best you can, which means you got to try and take all the precautions you can, and the dentists have to take all the precautions, the dental hygienists, the whole office got to take all the precautions they can. And the only thing that'll help us sooner than that is to get such rapid turnaround salival testing that you can walk in, get a test, and then go see your dentist if you're safe. So I think that's probably the only other move that we can hope for, and we're still a few months away from that, I think. So next question.
Good morning, doctors. It's John Pepitone over at Fox 4 News. I was wondering what you make of a report out of Johnson County saying that 911 calls for ambulance service have been down during this period of the stay-at-home order. And I think you kind of had talked about it yesterday, addressing the issue of people may be afraid to go to the hospital, and that's why we're seeing this happen.
Yeah, John, thanks for that question, because it gives me an opportunity to get on my pedestal about it. So I think that's right. There's actually early evidence out there that says that the number of patients dying from heart attacks and strokes has gone up, and that a number of those deaths are occurring at home because people are afraid to go get care. And I know we were just talking about a dental office and saying, gosh, at some point you just have to go see the dentist. I really think it's important for people to not neglect their baseline health problems. If you, and the story is, I think, the one that we've been hearing from some of our physicians. If people have crushing chest pain, they're coming into the hospital and they're having a heart attack and they're getting that care. So the rate of this, what we would call an ST elevation MI or a transmural MI, that people are still coming to the hospital for that. What they're not coming to the hospital for was that little bit of chest pain, a little bit of nausea, a little bit of a sweat, and so they're having small heart attacks at home, which unfortunately can continue in a stuttering fashion or can result in some fairly significant loss of heart function or arrhythmia. So that is a concern to us because we don't, there had been this hope that maybe because people were staying at home, they were taking their medicines, they were exercising, they were eating better, something had changed in our lifestyles that led to people having fewer heart attacks and strokes or whatever the health condition may be. What we're seeing, though, is emerging evidence that that's not the case, that in fact people are dying more frequently at home from these other problems. They're just afraid to go in the hospital. I don't know how we solve for that other than to staying on this message that you are safe in a hospital. And how are you safe? Well, here's the things we do. First of all, we take anybody who we even think could have COVID-19, we put them in a special unit. If you do have COVID-19, you're in a special unit. So we've done that, and that's called cohorting. And we've cohorted patients into those areas so that those patients don't, and the caregivers don't cross with the folks who are taking care of the non-COVID patients. And I think that's really an important step to let people know, look, we take this really seriously. In the emergency room, over a weekend, we built an entire bay for the emergency room in the ambulance bay. Ambulance drivers may not be super happy, but the reality is what we did is we created an area for COVID-19 patients in the ER so they're not mixed with everybody else. And now that we have really good testing capabilities in the hospital, we can test a broad range of people who come into the front door. And I think there will be a day in the not too distant future we may think about testing every patient who comes in the hospital to see if they have had it or have been exposed to it. We're certainly testing everybody before surgeries now. So I think that those things are what we're doing to keep folks safe so that people can feel safe about going to the hospital. And the last thing we can tell you is we don't know to date, and Dana talked about this, we don't know of any patient-to-patient or staff-to-patient transmission. Now, check me on that. I think that we had one there where we were a little worried, but I think we did the tracer tracing and it was all
so far
safe.
No positives as far as that goes. Yeah.
So we really, really work hard at that. And I think the interesting thing is, because we have been so vigilant on infectious disease, we are probably safer than we were before COVID. I think we were safe before, but what we've done with all the hand washing and all the preparation is it means if a staff member has the flu, well, they're not working because we check their temperatures when they come in every day. I think there's less transmission of disease from the hospital to you than there was prior to COVID-19. So I think in some ways it's actually a safer place to be.
In addition, all of our care providers now are wearing masks and they're doing proper things, again, to prevent any asymptomatic spread. So I think
folks see the images from New York and other areas or Italy and you think, oh my gosh, that looks really dangerous. And I think that's a different story. That is not who we are, thanks to you because you helped us bend the curve.
This is also a little plug here for telehealth. This is a great place for telehealth, right? For the management of chronic conditions, to prevent them from becoming acute. Telehealth is a great way to connect with your providers. Our cardiology team is seeing several hundred visits a day and still has more capacity, and they are willing to and more than happy to work with new or established patients around cardiology needs in both the chronic management of disease as well as acute settings, and they can really help you differentiate of when you should come in, what you should be doing, where you should be going, who you should be talking to with symptoms that you may have. And I think whether it be telehealth or a phone visit, other things, there's a lot of opportunities to connect with our healthcare team without necessarily having to come into the clinic. Yeah. But we also are still seeing patients live and in clinic. And so
still see it.
You can still come in and see our providers, and there is no substitute sometimes for that physical exam. We just want to make sure we're bringing the right patients in for the right reasons.
Yeah. Other questions? John, did we answer your question?
Yes, thank you.
Others?
Hi, this is Nate again. I have somebody who says they have a chronic condition and they want to know, how do you weigh isolation versus mental health?
Oh boy, that's really hard. That is the big question, isn't it? Okay, I'm going to start with Keith on this one. I'm going to assume a chronic condition means somebody doesn't want to come into the clinic. And so what do you think? What do you tell your patients or others about that?
Well, to be honest with you, this is where one of the reasons why I love telehealth. It's a great way to connect with the patient. and a great way to give them an outlet for, I actually have had a couple of patients who are isolated at home who need that connection more than they need to hear about their nasal congestion or their sore throat. It's more about actually, I just need some personal interaction. And so telehealth is a great way to provide that for our patients, and it's a fun outlet for me to be able to do something maybe a little bit different and meet a different need than I might for a person who's just coming into clinic. But I also think it's a great way to connect. Our behavioral health team is fabulous at counseling patients and helping patients through these difficult situations, and they also, shockingly, are on telehealth. So our entire organization has the ability to adapt to and meet our patients' needs through those virtual visits when they are struggling with this home isolation. So I think, don't forget that not only are your primary care physicians there for you, but our specialty physicians are also there for you to help you through these difficult times, not only in managing your chronic or acute conditions, but also some of the other mental struggles that go with being home and being isolated.
Is it safe to go out if you have a chronic condition, Dana?
It is safe. If you can do it in the right means and mitigate the risks, as we've been talking about, don't go out if you are having symptoms. Only go out if you need to. Cough in your elbow. Do the adequate hand hygiene. Don't touch your face when you're out in public, or if you have a mask on and manipulating the mask. But it is safe if you can mitigate those risks. And that's what we have been talking about. And we understand and have been cognizant of the mental health aspect and the emotional and spiritual aspect of all this since day one. Because certainly if you've had psychiatric diagnoses or problems in the past, this can unmask them or make them even worse. If you haven't, then this can certainly bring on situational type of issues too. But if you can do those things that we are trying to get through to mitigate your risk of getting infected, I think that will help a great deal. Yeah.
I think you have to know who you are and who you can really be. For some people, staying at home is pretty easy. I'm kind of an introvert. I don't mind it so much. My wife's a little more of an extrovert, and she's worked hard and done a really good job, and we do Zoom visits and things like that with other folks. But I think that the answer to this question is it's highly individualized. Again, you have to know who you are and who you can really be. So that for someone who just doesn't do well without social contact, you may have to take a little bit more risk. And yes, you have a chronic disease, but if you make yourself miserable or depressed because you don't have contact with others, I'm not sure that's right. When you do have contact with others, you try to maintain that 6 foot of distance and wear a mask if you can. But I think you have to know who you are. And for every individual, that calculus of weighing those risks and benefits is just a little different. I love to go fly fishing. I said yesterday, I like to go out to K&K fly fishers and bump around on a Saturday. I need to get to the river. I'm ready to take my fly rod, go stand in the river and wave a stick at some trout and hope they like me. And until such time, I say that every morning. We take a walk in Lewis Park. Did this morning, a beautiful day. And as I walked around, I could hear the birds, and the birds are always here on the river. I got to go. And at some point, I'm going to have to take the risk of travel to go to the river because that's who I am. You got to know who you are.
Right.
And that's just part of the deal.
And this goes, to Dr. Sale's point too. If you do have a chronic condition, that needs to be managed optimally. And if you can do that, you can keep yourself safe. And you can do that by keeping in contact with your medical teams, your primary care teams, either getting in to see a physician in person in the clinic, or if they think it's okay and you can get with the telehealth visit, then do that. But it's important and imperative to keep those chronic conditions managed as optimally as possible.
Yeah, and if you are sick, that's a different story, meaning that if you have a fever or chills or the things that sound like it could be COVID-19, that's a difference. Then you have to stay at home because you want to protect everybody else.
Well, I think there's a difference between physical distancing and social distancing. I'm not
really
necessarily a big
true.
fan of the social distancing term. I think physical distancing is better. I think still maintaining a way to create social contact is really important. Whether that is using a digital platform and Zooming your family, or if it's going for a walk in the park, or it's going to even just walking through the grocery store to get your vital needs for the week. Sometimes those all can be outlets to have some form of a social connection with other people that can help, I think, people work their way through these difficult times of being isolated at home.
Time for one more question and we'll have to wrap up. Anyone out there in our audience?
I have another question if nobody else does.
Okay, Nate.
Somebody was wanting to know what is the recommendation for personal social gatherings once the stay-at-home order ends? Like, going to visit an extended family member or to a friend's home.
Wow. Save the best question for last, Nate. I'm pitching. I'm going to see what Dr. Hawkeye thinks first.
What do I think, or what is it going to be? I mean, I haven't seen the documents of exactly what it's going to be. I know that there's probably still going to be a limit on gatherings to about 10, at least for the first phase. But again, I don't know. I haven't seen any documents or exactly how the phases are going to come out. I think, again, as we move forward, we know that COVID's going to be here. It's not post-COVID, it's a COVID world. You have to, and some people are better at this than others, you have to take risk versus benefit. What is my risk of doing this? What is the benefit of doing this? We know that certainly as we start to open up, there are going to be more people who are out in the public who are going to be susceptible to this disease. Right now, it seems as if one person can spread it to at least 3 or 5 other people. Those 3 or 5 other people can spread it to 3 or 5 other people. So you have to understand your risk of wherever you're going and the people that you may be around. And by taking those things into account and then doing your individual responsibility of trying to mitigate that risk with the hand hygiene and possibly the mask and not touching your face, things of that nature, and not going out if you're sick, you can mitigate and decrease that risk as much as possible, but nothing is going to be an absolute. And so I think taking all those things into account is really what you're going to need to do when you can get back out and some of these restrictions are lifted. But I think in general, there's still going to be a fairly significant restriction on numbers of gatherings. I think it's still 10, but unless you know anything more than that.
No, I think that is the number I'm hearing. But you know, the number of people in a gathering is really important because it does increase the risk of people being together and spreading it just because you have more people in the room. But, you know, this is an important consideration. We sort of touched on it earlier. A, SARS-CoV-2 is out there. B, the government has rules. C, there's personal responsibility. Now, you just have to think about those 3 things together. And then D, we know what to do for infection control. So the government may say, okay, we're taking away some of the rules about gathering and being out and opening business, all of which I get. I mean, we have to have an economy. People have to have a job. I'm not complaining about that. But as individuals, it doesn't say that our personal responsibility just left the room. Actually, your personal responsibility just went up because it's easier to to obey rules of infection control when you're sheltered in place at home. It's harder when you think, okay, I can go out in public now, because then you have to be even more observant. And so I think even as government opens and businesses open, the rules of social responsibility and infection control haven't changed and may have even put a bigger spotlight on them, because how we conduct ourselves as we go back into the world and back into society will define how SARS-CoV-2 affects us, your loved ones, your health systems, and the ability to keep businesses open. If we do the wrong thing, we'll see that rapid surge, and then we can be back in trouble again. If we do it right, we're going to have SARS-CoV-2 for a while, but it won't be the rapid, overwhelming surge. It may be even, it likely will be more than we have right now. But it has to be kept at a level that it's manageable. And as individual folks, unless you want to see your family or loved ones suffer from it, you have to follow those rules of personal responsibility around infection control. I actually think that's the most important message of the day.
Absolutely.
I want to say thanks to everybody. We're back at it tomorrow. David Wild, the real David Wild, not AKA Keith Sale. The real David Wild will be here with Terry Sue. We're going to talk more about this question of modeling, what's going to happen in society, and how we're trying to keep people safe and testing before surgery, especially in cancer patients. Thank you all very much. See you tomorrow.